Hello.
Good evening, ma'am. Hello.
Hello.
Hello, ma'am. Can you hear me? Hello. 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 Can you hear me? Hello. Hello. Hello.
Hello. Hello.
Hello, ma'am. Hello.
Hello. Hello.
Ma'am,
Hello. Can you hear me?
yes, ma'am. I can hear you, ma'am.
I'm just checking my microphone.
Okay. Ma'am, can you hear my voice?
Hello.
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 जहाँ पे आपको सस्ता होगा वहाँ पर
Hello.
Good evening, sir. Just a minute, sir.
Pairing mode. Waiting for device to connect.
एक तो मेरा सेशन चालू होने वाला होता है
नहीं अभी कोई नहीं आया उमेश सर को जाने
Hi, good afternoon. Hi, Jamuna.
Hi, good afternoon.
Good afternoon. All good?
Good.
Hi, sir.
हाँ अभिषेक जरा वो YouTube का लिंक सब जगह भेज दो।
हाँ मैं भेज रहा हूँ।
Good evening, sir. Good evening, madam.
Good evening.
Ma'am, you want to share your screen? You want to check your PPT, ma'am?
Hi, Nirmal.
Hello, Dr. Mittal. How are you?
I'm fine.
Fantastic to see you after the ages.
Yes. Long time no see, long time no meet.
Yeah, COVID time.
Yes. True.
Vidya has not yet joined.
No, doesn't look like it.
Abhishek.
Hi, Krish.
Hi, good evening.
Good evening. How are you?
Very well, thank you. Nice to be meeting
Yeah,
here.
nice to meet you all.
Yeah, hi Krish.
Hi, Nimmel, good evening.
Hi, good evening.
Hi,
I was-
Dr. Mitchell.
I was there in your Ayurvedic program
Hi.
and I asked for a question, but I think
Yes, I saw that and I hope he answered your question properly.
I don't remember. So I think we will connect with him someday.
Absolutely.
I was traveling to Bangalore, so
Acha,
maybe
acha.
after that some people have come. So went for IronCon inspection, so we will have physical IronCon at Bangalore.
In Bangalore, right. Is this going to be at Nimhans?
No, we are doing at Clark Exotica Resort.
Okay.
No, that's very near the airport. No,
Yeah.
it's not in the city proper.
So it's outside only, but you know,
Yeah,
they were the largest auditorium of 3,000 people. So that means as per today's law, we can have 1,500 people physically present in the country. 50% they allow.
Super. You'll have a big crowd.
I hope so.
One of the first conferences post-COVID.
Yeah.
Post-lockdown, I mean, not post-COVID. Right.
Let's see how it goes. We will.
I mean, if few people are involved, definitely it'll be a success.
We'll try our best.
Right.
I'm going to take over as president there.
I know, I saw the thing.
Wonderful.
Saw the-
Congratulations.
Thank you.
Hi, Krish. Hi, Dr. Mittal. How are you?
Hi.
Hi, Abhishek.
Hi. All good?
All good, thank you. You have no space left behind you, yeah? All those awards.
Slowly, he's going to construct a cave around him.
We are 5 minutes to start here.
Vidya
Vidya,
has only not joined.
I just messaged Vidya, she's joining here.
Good evening, Dr. Mittal. First time I'm meeting you.
Yeah, hi.
Hi. Nice to see you all.
Yeah.
Mittal has been a very, very dynamic I would say, neuropsychiatrist in Mumbai. Unfortunately, he left Bombay Hospital, so made us orphan here.
Oh, I had to make place for you, na. वो कहते हैं पाली में दो मगरमच्छ नहीं रह सकते ना.
So we had a lot of meetings together. I remember that Varanasi thing.
Yes. No, even after that, we've had a lot of talks together.
Yes.
But it's been some time. Now I'm at the national level, so I'm the national president of the private psychiatry. So I think for the next 4 years, we'll do a lot of work together.
Yes, so you are the president for the private psychiatry. So let's do something together, neuropsychiatric session. At least from December onward.
Yeah, neuropsychiatric basic this thing we can pick up and start working on it.
Once a month webinar for resident and young this thing.
Yeah, definitely. I can put it up. I have, in fact, I have a website registered, which I have not started. I mean, I have a domain name registered. Controversies in Neuropsychiatry.
So let's make it a program once in a month on different topics.
Yeah.
And so that people can be very clear about it. And so we will discuss on this.
Yeah, definitely. We can start with simple case presentations or something, which have commonalities between both the disciplines.
Yes.
Right.
But there is so much of overlap. Chris has been here.
Yeah.
He has been. I've always been troubling him.
Right.
It's always a pleasure to be troubled.
No, but you've been the pioneer, no? In the beginning, you were the ones. I remember the first time you would partnered with Murundeshwara was when I had come for the conference in Chennai.
Right, sir.
Yeah, and I'd met you then. Then I met you with Parminder, I think.
Yes, Parminder
that was
times.
You and I met with. I mean, we met when Parminder was president in Sydney.
Right. Yes. Yeah.
So we
So
met.
Since we are live on YouTube, I think we should.
We can start.
Just.
We are joining in 2 minutes from the MOH session.
Okay.
We are joining in a couple of minutes.
So we wait for Vidya because she is the.
Good evening, everyone. And let's have a great session.
Right.
Thank you, Dr. Surya and Dr. Abhishek. Don't have words enough.
Most pleasure.
Thank you. Let's start. We are in time, 4:30 sharp.
So what Avinash is joining?
Dr. De Souza has not joined till now.
No, sir, I'm here. Good evening.
Okay.
Yeah. Hi, Avinash.
Good evening.
Hi, sir.
Hi.
Sir,
all set.
Sir, should I open the webinar, sir? It's
Yeah,
already.
please.
Yes, please open.
it.
Okay.
Yes.
Sir. Sir, the webinar is open now. Attendees can see and listen to us, sir.
Right. We all ready and set to go.
Dr. Surya, we can start.
You give us a countdown and start.
The people are joining. Wait for 2 minutes. Let people join in. Already a lot of people are waiting, so they have joined now. Give 2 more minutes. So Vidya, I will just start the session and give it to Abhishek, who will continue that and then hand over to you. as a moderator. So we begin. Am I audible to everybody?
Yes, you are.
Perfect. So good evening, friends. I'm Dr. Nimmel Surya, the President of Indian Federation Neuro Rehabilitation and President-elect of Indian Academy of Neurology, is here to welcome you for the special session on World Alzheimer's Day, which is 21st September today. And today's session has been specially brought to you with the effort from IFNR, which is being supported by the World Federation of Neuro Rehabilitation. And we have been now celebrating 25th anniversary of World Federation of Neuro Rehabilitation. And we're jointly being supported by ARDSI, the Alzheimer Society of India, whose president is Vidya Shenoy and secretary is Avinash De Souza. And I have a galaxy of people to talk about Alzheimer's disease. Who else than E.S. Krishna Murthy, Jamuna Ranjan, and Anukant Mintal. And not to forget Abhishek Srivastav, the rehab specialist of the country, is also been there to guide us. How do we take care of people with Alzheimer's disease? So with that welcome note, I hand over to Abhishek to say a few words and start the proceeding. Abhishek.
Good evening, everybody. We have a multidisciplinary team of neurologists, neuropsychiatrists, psychiatrists, rehab physicians, neuropsychologists, keeping in principle of IFNR and WFNR to take this webinar forward. I would first like to welcome our first speaker, Dr. Nimmel Surya. Doesn't need any introduction, just a formality, I would say. He is the neurologist at Bombay Hospital and Saifi Hospital and at the Mumbai Police Hospital also. The chairman of the Nimmel Surya Neuro Center, trustee of Epilepsy Foundation, founder president of IFNR. He is the president-elect for Indian Academy of Neurology. He is currently the member at large of the president of WFNR, also chair of the ICHA Telemedicine Academy. It will keep on going on for hours if I keep talking about him. Will not waste time. I'll call sir for this talk on Alzheimer's disease and overview.
So before I speak, I would like to introduce Vidya Shenoy, who is the moderator for today. So can I have the introductory slide of Mrs. Vidya Shenoy? She is the master's in economy and in management of yoga and pranayam integrative therapies creative. She's also art, dementia care, geriatric counseling. She is a integrative therapist and dementia care specialist. At the moment, she is the Secretary General, Alzheimer's and Related Disorders Society of India. She has remained as honorary secretary for Mumbai chapter, Maharashtra chapter, and she is also the founder of Smriti Vishwam Universe of Memory Dementia Daycare, which was awarded ISO 905 in 2015. So basically, she has been very passionate about working as an expert in dementia. And I had connection for last 2 or 3 years, ever since we did World Federation, World Congress Neuro Rehab. And I found that she's been very much involved and want to take care of people with disability, in particular with dementia. So I welcome you, Vidya Shenoy, and it will be very nice that you would be moderating today's session. So with that note, let me start in next 5 to 10 minutes about Alzheimer's disease. So if we can have, yeah, perfect. So as I already mentioned to you that today is the World Alzheimer's Day. And I am very glad that we are not only telecasting or viewer from India, but I have my very close friend from Mongolia who has been involved with the World Federation of Neuro Rehab, and I welcome her to our webinar. She's a very, very expert and working in Mongolia. So it is the 10th year of campaign that the World Alzheimer's Day has been celebrated on 21st September. The campaign started in 2012. Now, if you look globally, brain is a very, very important organ, and we all know that there are 100 billion nerve cells, and there are 100 trillion synapses which connect these nerve cells. And though we are sleeping or sitting ideal, but brain never sleeps, it keeps on working. Though as age progresses, these cells start going with, I would say, getting dead over a period of time, slowly, or maybe with respect to certain diseases, faster. And that's where the problem comes. If you look at magnitude of Alzheimer's disease and related dementia in India, there are nearly expected to be about 4 million people suffering from Alzheimer's disease or some form of dementia. And there it is, the brain no longer works as it should work normally. And you should also know that the lifespan of Alzheimer's disease, once it has set in, is nearly about 8 to 10 years. So it is not a very rapidly progressive illness, but it is a very, very slowly progressive illness. And many times the family people do not realize that the patient or the person in their family or their parent has Alzheimer's disease. They just think that it is something normally happening. And by the time they realize that, oh, something is wrong, it is already 4 or 5 years have passed. Like 4 days ago, I saw this lady who stays in a rural Maharashtra, and she has been having forgetfulness going on for last 4.5 years. It is only that last 6 months that she has started some hallucination, and she has been having behavior abnormalities, repeatedly asking the same question, that relatives started wondering and worrying that something is wrong, and they have come for the consultation. So this is what is more often happening in our country, particularly in the people who do not have awareness about the Alzheimer's disease. So Alzheimer's disease, the first and foremost problem is trouble with the memory. And that means when we are talking about what sort of memory getting affected, we will say that it is the difficulty in record information which is learned. So if you are having this problem, that is, if suppose a person cannot repeat what he's been done, or he's forgetting that he had the breakfast in the morning, he cannot recall what he met somebody, or he cannot recall where he is, that means something is wrong. And then they have some trouble creating the simple task. You tell them to draw a clock. So the simplest thing we do in examination is ask him to draw a clock and say, suppose it is 4:40, we'll say, okay, draw the 4:40 in a clock, or copy something, or the name certain animals, or name certain birds. So these are where the person start having difficulty in replying to you. Then there can be changes in the personality, and I'm sure both Krishna Murthy, ESK, and Anupam Mittal is going to talk about the personality confusion and behavior abnormality in greater detail. And sometimes they can also have visual images, which again, they're going to tell us. And it is the hippocampus area of the brain, which is the temporal lobe, which is to start with first affected, and that's where the memory is located. And then it is the frontal lobe, which is in the front. When they start getting affected much more, then you get personality and behavior disorder and behavior changes. Now, somebody would ask, what are the risk factors? And the first and foremost risk factor is age. So as you grow age, the higher the age, the more number of cases would be around. And you know, in America alone, there are about 6 million patients, and they expect that by 2050, they will have 14 million American will have Alzheimer's disease, and which will be the 6th leading cause of the death. So that's very alarming. So age is one. Then if there is a family history, somebody in your family had Alzheimer's disease, you have a higher risk. And therefore the family history of genes can be a problem. But there are certain genes, like ApoE4 gene, that can give rise to Alzheimer's disease. So these are the genetic disease. And then the environment exposure, certain disorder like hypertension, diabetes, giving rise to multiple infarct in the brain. So multi-infarct dementia. But we need to rule out between Alzheimer's disease and other dementia, which can be treatable. And therefore, when a patient comes to us, before we diagnose Alzheimer's disease, we really like to know if this patient has any one of those treatable dementia, like multi-infarct dementia, normal pressure hydrocephalus, or B12 related dementia, or other form of dementia. So we look for that. Mind you, there are other group of disorders which are rapidly progressive dementia, and they need to be differentiated because there the treatment is different. Now, diagnosis is most of the time is on history and examination. You know that person is forgetfulness, he's slowly been progressing, he's been having this difficulty, and we do various tests. And I'm sure Dr. Jamuna is going to tell you about various FAB and COM and everything, which I'll simplified way, that if you can do those simple tests, you can pick up that if the person is having early indication of Alzheimer's disease. And if we can diagnose at MCI, that is minimum cognitive impairment, then the treatment can be a very effective, and we can delay the person. So now the question is how the treatment comes. There are various drugs available which can increase the chemicals in the frontal area and the temporal area. These are known as acetylcholine in a receptor enhancing drug. Then there are other drugs which are through the dopamine. So these are the various drugs which can be started, which definitely help. Dr. Mittal is going to talk about taking care of patients' other problems like injury and etc. So he will talk about the need and role of psychiatric drugs in this particular patient to avoid injury and fatalities, etc. Because many times these are the patients who remains in their own world. They sometimes just walk through, and you will hear many of the stories. I'm not going to discuss in detail, where the person was just sitting in the park and suddenly disappear, never to be found, because it lapsed from the siblings for even for few minutes, and they found that the person has walked away and they disappear in their own way. And there's no way they can tell where they have to go, what they have to do, whom they have to contact, and they are never found. And these are the stories you will find with the police people all the time. So there are newer drugs are coming. Before I stop, I want to just say that in future, the Alzheimer treatment would be different. As you know that FDA has approved it rapidly in a couple of months before a drug which is known as aducanumab, which is an adulam from Biogen. And this drug has emerged as one of the very interesting drugs to reverse the MCI and early Alzheimer's disorder through the emerge and engage trial. And I'm sure there would be many new trials and drugs would be coming in the future, because many of the researchers are focusing as this is going to be a leading cause of death in the future as the age has been advancing. So with that note, I will stop here and we will take your questions as Vidya will put forward, and I'll take it forward to the next speaker. Over to you, Vidya. Thank you very much.
So, Dr. Surya, it was a wonderful talk you gave. It, would help anyone who is not aware of it at all, or somebody who has little information. And I think we should all be hungry to know more, so nothing goes waste. Wonderful. And what I liked about this was not only did you talk about the disease itself, but you also gave examples and practical examples which happens. And these are the main challenges I think we have to handle these problems. And you've also given hope that more things are going to come up which are going to cater to. So now may we go to the next speaker, please? I have the privilege of inviting Dr. Jamuna Ranjan, and we know that she is the head of the faculty in NIMHANS, and she is working in the clinical neuropsychological department of cognitive neuroscience. She's got a lot of things to her credit, her publications, her experience in the rehab area. And I think her specialization in clinical neuropsychology has been pioneering in the area of holistic neuropsychological rehabilitation. She's got endless degrees, endless papers that she's presented. And without wasting time, may we request her to take over and address us. Thank you, Dr. Jamuna Ranjan.
Thank you, Dr. Vidya, for this kind introduction. At the outset, I wish to thank the IFNR, Dr. Nimmel Surya, and Dr. Abhishek Srivatsava for inviting me for this very important topic, this panel discussion. I've been given a topic of rehabilitation, the challenges faced in Alzheimer's dementia. So what the format of my presentation is going to be as follows. I will just touch upon what dementias, the different stages, and as we all know, the carrying out rehabilitation in dementia is very, very challenging. Now, what happens is, it's just not the cognition. It is also the psychosocial factors which play a very, very important role. In fact, I would say 75% of the rehabilitation should be in the area of psychosocial rehabilitation, and cognition comes only at the initial stages when the patient has the mild cognitive impairment. So if you look at dementia, dementia is varied and typically include symptoms of all dementias: memory loss, problems in speaking, communication. When I say communication, it is word finding difficulty, repetition, problems in focusing, impairment in judgment. They also have struggle completing the tasks and has difficulty comprehending what we say. So once we look at the stages are only when the patient is diagnosed as having progressive dementia, the stages come in. There are several stages from 1 to 7. I won't go into the stages. It starts from no impairment to severe impairment. Some of the key aspects one needs to keep in mind while carrying out rehabilitation in dementia patients is, as I told you, the psychosocial factors play a very, very important role. One needs to have a look at or inquire about the home environment. They have to evaluate the capabilities of the patient and the significant others. And they also need to involve the patient as well as the significant others and the family members. Introduce small incremental changes that you can carry out with the patient. Most often you have to use the role play to demonstrate to the support of the skill building of the individuals. Readjustment strategies is implicated, and what we need to aim at is we should engage the individual through the day with some kind of activities. Now, when I say that rehabilitation should also include quality of life, that is the most important aspect, because these people they do not, especially in the moderate and the severe stages, cognitive rehabilitation, we have very, very little evidence that the patients have benefited from cognitive rehabilitation. So what we need to understand is we have to look at from the individual, from the caregivers, and the environment. There are 3 segments that one needs to look at. When we talk about individual, we have to look at the underlying medical causes. They do have the comorbidity of depression also, these dementia patients. What are the cognitive deficits that is existing? So through the assessment, I'll come what kind of assessment that we need to carry out. We need to assess them for cognitive deficits. Then their sleep hygiene. needs to be covered. Their aches and pains should be taken into consideration. They're disengaged. They are always disengaged. So we have to give some tasks to keep them engaged. And they also have risk of falls. So this has to be told to the significant others and the caregivers. And the fear, they have fear, loss of control, loss of, they get lost when they get outside home. These are some of the things when you consider the individual should be taken care. And when caregivers, we need to communicate, not to shout at them, yell at them, treat them harshly, use bad languages. Their tone has to be very polite. Their expectations has to be taken into consideration. Their stress level also should be taken. As a clinical psychologist, what we do is we also handle their stress levels, and also their routine needs to be told to them how to carry out different routine in an individual as a caretaker. And they also, their interpersonal relationship should be good with the patient, and their coping skills also need to be kept in mind. When you look at the environment, one needs to take care of the noisy. The noise also can add to their symptoms. If it is too cluttered, the patient gets lost. Too complex, that needs to be handled. And overall, understimulation is another thing that which we need to keep in mind. So now I'll go on to the different stages. So preclinical stage, once when they come to us, many a times in the preclinical stage, patients do not come to us. They only say, these days, I don't remember as I used to do before. And when these individuals are subjected to any kind of imaging, their imaging doesn't pick up any kind of a pathology. It is only the neuropsychological assessment that can pick up the deficits, but very rarely do they come reach us. It is only in the mild and the early stages that they reach. In the mild stage, we see that they have forgetfulness. They are continuing to live independently, and their interpersonal or the activities of daily living is good. Their interpersonal skills are good, but what they have is remembering names or recalling recent events, or remembering where they have put their valuable objects is what their concerns are. And when they reach us at this stage, we do have cognitive retraining, and we do have elderly battery, neuropsychological battery, where we can pick up the deficits and then administer some cognitive tasks to delay the progression. My moderate stage is the most difficult stage. When they reach us during this stage, it is very, very difficult to rehabilitate them cognitively. I can give you an example. There was an undersecretary who came to us with a moderate stage of dementia, Alzheimer's dementia, and out of my own enthusiasm, I started doing the cognitive retraining. But to my shock, I saw the patient deteriorating in 3 days. He just deteriorated so badly that we could not do anything further. Of course, this was way back, about 10, 15 years back. Ever since then, when the patient is in the moderate stage, all we do is we do other forms of therapy other than the cognitive rehabilitation. And of course, severe stage, we do not have much of or the help from the cognition side. We do not offer, don't have much to offer, but yes, psychosocial interventions can be carried out. So I'll just move on to cognition. What is the goal? To make their life more meaningful, to help them to be much self-sufficient as possible, and to improve overall quality of life. So what is this cognitive rehabilitation? It is an application of techniques and the implementation of support to allow individuals with cognitive impairment to function as safely and independently as possible. So there are various assessments. So most of the complete neuropsychological assessment can be carried out only at the mild cognitive impairment stage, but at the moderate and severe stages, we just need to do mini cognitive scale, clock drawing test, mini mental status examination, Adam-Crooks test. We also have NIMHANS neuropsychology battery for elderly, where we carry out, of course, we have a score which says what is where the patient is functioning, which is the domain that it is functioning. We also know that in the mild stage, there can be one or more domains that is impaired. When I say domains, cognitive domains are attention, executive functions, perception, and learning and memory. So there can be impairment at those stages in mild, one or more domain. In moderate stage, you just see diffused involvement, that is, they have impairment in all the domains. A severe stage, we may not be able to carry out any of the simple cognitive tests, even in this in patients. So what is the what we do is we by enhancing and ensuring how we can optimize their preserved abilities, we tailor make the task and administer it. We minimize the needs of their lost abilities and provide necessary attention and assistance for better functioning. So what we do is we give very, very simple tasks. Now, what happens is if a person is pre-morbidly was high functioning, then it becomes very difficult for us to carry out the neuropsychological assessment. I can just give you a very recently, a lady with who was the director of a medical college came to us. She had severe personality issues. She had agitation, anger. She was very abusive and very irritated. So what happened is when we subjected her, the family members brought her only for the personality issues, not for the cognitive issues, because she wouldn't, she had a lot of denial. She was in the mild to moderate stage. She had denial that she had any cognitive problems. So when we carried out neuropsychological assessment, we saw a diffused involvement in her. But to give even that feedback to her was very difficult because she wouldn't accept. So this is the stage where we need to work with the individual, even to work on their personalities. We do have tests, we do have neurofeedback, which can first improve their personality. So this is what we also do is, in the mild stage, what we start off doing is the remedial therapy, and also reality orientation we give to them, and activities. We focus on more of activities like music, dance, sports. We ask them to practice even at home, and environmental modification is carried out, behavioral modification is carried out, and use of any adaptive equipments we ask them to carry out. And cognitive retraining is given paper pencil tests initially in the mild stage only. We give paper pencil tests, we give some memory tests of and attention tests. In the moderate stage, what we do is we do not focus more on the cognition, but again go on to reminiscence therapy, where we establish behavioral routines and habits with the patient. Compensatory strategies, we start structuring their environment. Mindfulness, the method we use. We also provide them with verbal and physical prompts, and time management, keeping a notebook, use of calendars. And what we also do is very minimal cognitive tasks where we see that some cognitive domain is preserved. We administer the cognitive task. In the severe stages, what we do is, it is nothing, we cannot do much of it. We also see diffused involvement on the cognitive test. So compensatory strategies, positioning in the wheelchair, bed stimulation, therapeutic intervention, which includes balance between attention to the future and to the past, and to add life to the present. So caregiver intervention is very, very essential at a severe stage. Some of the guidelines that we give for the caregivers: to maintain regular routine, rhythmic routine with the patient, orientation to be carried out, time, date, month, year, etc. Participation in various activities the caregiver has to ensure that the patient follows, and avoid frequent changes in any kind of arrangements. Avoid morning naps, afternoon naps. Maybe they can just rest for a while and never retire. They have to continue working, and unconditional positive regard needs to be provided by the caregivers, and maintain calm and concern should be there. Thank you very much. With this, I end my talk.
Thank you, Dr. Jamuna, for very enlightening. You have simplified the care of people with dementia and Alzheimer's disease in a very simple way. It'll help many people to understand this complex issue. Thank you very much.
Thank
The
you.
next speaker is Professor E.S.
Abhishek, I
Krishnamurthy.
will request people who are there in audience, if they want to ask the question, they can just put it in the question and answer, and we will take them in between to the relevant speaker. So you can put your question in question and answer, and for whom you want to ask. Thank you.
So our next speaker is Professor E.S. Krishnamurthy. Can you play his slide, please?
Is my slide visible?
I have to formally introduce you, Krish. 1 second.
Of course, yes.
Can you play CV slide, please? Professor Krishnamurthy is the founder of Buddhi Clinic Chain, which offers integrated and holistic brain and mind care services. He's the immediate past president of International Psychiatric Association. He's an international academic leader with multiple professional affiliations. He was awarded by the Royal College of Psychiatrists, published many papers, many books, a social impact leader in healthcare, very strong track record. Also, he has a book, Beyond Feeling and Emotional Brain, to understand brain interface. The best speakers known on this field. Floor is yours, Professor E.S.
Thank you, Dr. Abhishek. Thank you to you and Professor Surya for inviting me to do this. Can I have my slides back? Request the digital team.
Sir, you can share your screen, sir.
Sorry, I'm okay. Sorry, I've lost my slides. Just give me a moment. Are you able to see my slides?
Yes, sir, I can see your screen, sir.
Okay. Yeah, in the process, I think I seem to have lost my slides.
We cannot see you, Krish.
Yeah, exactly. Just one moment. I'm trying to screen share, but without success. Just give me a moment. Yeah. Are you able to see me?
Your family, we are seeing.
Your screen, sir.
Okay. Okay.
Yeah, it's there.
Good now?
Yeah, it's there now. Come on.
Okay, thank you so much. I've been asked to talk about the integrative approach or the holistic approach to rehabilitation in dementia. And I'd like to thank Dr. Surya, Dr. Abhishek, and everyone else in IFNR and ARDSI, Mrs. Vidya, for inviting me. We have to ask ourselves first, why integration of care? The first thing I would say is that advances in science are slow and that advances take time to reach the developing world. It took CT scan about 20 years to come to India. And when it did, it came to the All India Institute. It took a long time thereafter to generalize itself. There is then a 4A gap in healthcare. Problem of availability of healthcare, the problem of affordability of healthcare, the problem of acceptability of healthcare. Is the healthcare delivered to me acceptable? And the problem of accountability. Are people who deliver healthcare accountable to the person receiving it? And those gaps need to be filled by any good service. Today in the West, we talk about biomarkers and personalized medicine as what is the future of dementia care. This will take a decade to become a reality in a lot of the West. It will probably take 2 decades to come to low and middle income countries, or even 3 decades. And therefore, that is not the only answer we should be looking for. And beyond the medicines we have, the acetylcholinesterase inhibitors, the NMDA agonists, some pro-cognitive agents. And now, Professor Surya talked about aducanumab, which is very expensive and very exclusive, $54,000 a year. What is it that we have to offer our patients? The other question we have to ask ourselves also is, how does integration help? It taps into a very important barrier in healthcare, which is acceptability. It brings to the sufferer treatments that are closer to his or her concept of healing. Take Ayurveda, for example. In India, Ayurveda is very close to our mindset. We accept it as a form of healing, as a healing science, and therefore it closes that acceptability gap. Integration focuses on the reduction of suffering. Professor Jamuna Ranjan spoke to you about quality of life. So the two things that are important when you have a progressive disorder like dementia are retained activities of daily living and a better quality of life. And integration helps with that. Third, and most importantly, unlike many countries, the care of the person with dementia in India is with the family. And integration helps the family involve themselves in the caregiving. And families feel a sense of satisfaction when they are able to care for their loved one. So if you have a relative with Alzheimer's disease or any other form of dementia, you need to be empowered. And integration has the power to do that. This is a wonderful paper about the importance of family as a social support system in old age by Shanas, published in 1979. I would request everyone, especially healthcare professionals, to read it. Please understand that complementary and alternative medicine and integrative medicine is not unusual. Even in the West, in the Veterans Affairs Administration hospitals of the US, where all care is free, 40% of adults with neuropsychiatric symptoms were taking alternative care outside the system. And that tells you about how people seek alternative care. So as you've heard, the current drugs are marginally effective. What you've not been told is when someone adds a psychotropic drug, like an antidepressant or an antipsychotic, to the regimen of a person with dementia, the morbidity, the problems can actually increase. While it could help the behavior, the person could have other problems when you give them psychotropic drugs. And this is something which is well published and well understood. And today, non-pharmacological interventions, the evidence is growing. We have published papers on neuromodulation, published papers on the role of exercise, Tai Chi, yoga, various forms of cognitive stimulation, and caregiver training. And preventing institutionalization, encouraging family care, and maintaining activities of daily life and quality of life have become extremely important. Another thing we've learned from the West is that the economics of dementia have taught us this, that it's more sustainable for the family to care for the person, or the family to be facilitated to care for the person, than to do institutional care. Institutional care is not just alienating for the person with dementia, it is also extremely expensive. So whether we go to personalized medicine and biomarkers or not, we still need to talk about caregiving. And at the end of the day, that is not going to replace this, and hence integration is important. So what do you integrate then? You can actually integrate a whole range of what we call non-pharmacological or non-drug healing systems, including healthcare traditions that are locally available and culturally acceptable. I talked about Ayurveda. Yoga has become India's greatest export to the world. We have in India various streams of naturopathy, Unani, Siddha, homeopathy. We have, therefore, a richness of healthcare tradition. In China, the Chinese have already started integrating traditional Chinese medicine, or TCM, into the care of dementia. Integration just doesn't mean making something available. It also means creating a seamless model of care. And it's very old hat for care to be prescriptive. There needs to be an element of client choice. The person with dementia, if capable of choosing, certainly the family of the person with dementia have a role to play in what treatments they would like to bring into the mix of care that the person receives. And what we are trying to do at Buddhi Clinic is to bring together the best of modern science and the wisdom of ancient healthcare traditions, which is what I'm going to talk to you about briefly now. It's also important to remember that when you take activities of daily life and quality of life, and say, for example, behavior or physical disability as your outcome, it's possible to track it. It's possible to see whether people get better. What we are showing, therefore, or what we are trying to show, is that it's possible to blend modern science with ancient wisdom. It's also possible through our foundation, we are showing this, that we can blend corporate efficiency with humanistic equity. Both are important in healthcare. So we have over 12 years, touched over 12,000 lives, delivered over 120,000 interventions for a range of neuropsychiatric disorders. We work across the lifespan. In recent times, people have started talking about multidisciplinary and multi-component therapy. This is what we've been doing right through. We start with a best of class assessment and diagnostics, so we don't leave modern science behind at all. And as I was trying to say, we try to ensure that the care is holistic and the impact is measurable. Every one of our centers, we offer all these things. We offer neuromodulation, which is different forms of brain stimulation. We offer psychological therapy by trained psychologists. We offer speech and swallowing therapy. We offer various manual techniques, acupressure, acupuncture, reflexology. We have a house of naturopathy available, water, mud, and herbal preparations. We offer yoga. We have physical and occupational therapy. And we offer a full house of Ayurveda, oils, medicated poultices, and herbal preparations. In all, we have 15 interventions under one roof. This is the team. We have allopathic physicians, we have neuropsychologists and counseling psychologists, we have physical therapists, occupational therapists, we have a neuromodulation lab which offers transcranial magnetic stimulation, transcranial direct current stimulation, and transauricular vagus nerve stimulation, of which TDCS or transcranial direct current stimulation is a small apparatus, goes to the bedside, and is enormously helpful in managing both cognition and behavior and dementia. We offer, as I mentioned, we have Ayurveda, naturopathy, and yoga doctors. We have therapy assistants who deliver the basket of therapies. We carry out a whole range of tests, and we have a whole rehabilitation facility with speech, swallowing, and occupational therapy available. That's a snapshot of the team. The Buddhi way is 360-degree. Care is in our centers. We have centers now in Chennai and Coimbatore. Care goes to the doorstep. 20% of all our care is delivered in the patient's house. We take care to the hospital because people with dementia and various other neuropsychiatric conditions do get admitted with clinical worsening. And what I'm really, really happy about is that we've taken care online with do-it-yourself kits, which we courier to the patient and we support them online through video call so that they can give themselves care. And this is proving to be extremely popular and extremely helpful to a lot of patients. This is just a snapshot of people who had TDCS-led care. So they had TDCS, they had psychological support, they had other holistic therapies, and a very large proportion improved in their mini mental state examination score at 8 weeks. I can't show you a lot of slides because of the time constraint, but we have this data. So what I'm trying to say is that we do have a model integrated therapy program for neuropsychiatric disorders across the lifespan. It's showing very promising trends in managing neuropsychiatric symptoms in the elderly, including and especially those with dementia. Beyond medication, all these therapies have a huge role to play in improving activities of daily life and quality of life and reducing caregiver burden. And with non-pharmacological treatments becoming more and more important, our model, which is process-driven using a cloud-based EMR, may be a scalable model for pilot studies and research world over. I love this slide, so I'm putting it up. We are Atmanirbhar in spirit, in very much the fashion of modern India, where we are bold and we're willing to take what we can do in India to the rest of the world. Thank you so much, and I'm very happy once again. Congratulations to IFNR and to Artsy for putting this together. Thank you so much.
Thank you, Professor Krishnamurthy, for a very brilliant talk on the holistic approach of managing people with dementia. I'm really impressed by the amount of work you're doing, keeping all these things together and being Atmanirbhar in providing those services. Thank you very much. Thank you. Please unmute your mic. Dr. Vidya, please unmute your mic.
We go to the next speaker of the evening, Dr. Avinash De Souza, who is the consultant psychiatrist and founder trustee of De Souza Foundation, Mumbai, and he's the president of the Bombay Psychiatric Society. He's also a research associate at the Sion Medical, that's the LT Lokmanya Tilak Municipal College, and writes a lot, and conducts a lot of awareness talks, and very closely associated with schools and colleges on the educational front. Dr. Avinash, could you please take over?
Yes.
Thank you.
Well, good evening to the esteemed panelists and all the audience. I have a very different kind of a talk here today, and the talk is primarily on what dementia means to me as a psychiatrist, as a doctor. Well, I was never really a person who did work in geriatric mental health, and it was only because of being associated with some old age homes where I used to visit, and I had to treat a few patients there, that I came in touch with dementia. And that's where the whole concept of what dementia is, how it manifests, etc., came into my realm of understanding, and I began to develop an interest and to look into it. What amazed me about a disorder like dementia is that how it could probably corrode, erode, corrupt a brain that was so brilliant at one time, and over a period of few years cause deterioration to the extent that the person forgets a lot of things, including himself at times. And in some people, why is it that it is very progressive? In some people, why is it is less progressive? Why is it that you have a plateau followed by progressions? So this is something which was quite, the heterogeneity of the disorder is something which was very, very amazing. Apart from that, what was very important was that my interactions with patients that had dementia, and my interactions with patients primarily made me realize that there were some aspects of dementia which probably the textbooks didn't tell us. Some aspects clinically that weren't ever spoken about but were very important and vital. I used to have many of the dementia patients who would probably hold my hand, irrespective of their gender, and probably just try to touch my face and get an understanding of who I was. And that's when I realized why touch was so important to them. And that's when I began to even tell staff in an old age home that if they even hold your hand while you're feeding them, or they hold your hand while you're probably taking their blood pressure or something like that, don't look at it as a boundary violation as we're taught in a textbook. We have to understand that it's coming from someone who is suffering from a disorder like dementia. I had this particular person who was 83 years old, diagnosed with Alzheimer's. And for whatever reason, whenever I would go to visit him, he would refer to me as Chunilal. And I would wonder, why he would probably call me that. And I would tell him, I'm a doctor, this is my stetho. No, he said, Chunilal, aap doctor kab ban gaye? That was always his thought. And it's only when I had a chance meeting with his son that his son told me that, you resemble his school friend, who of course has passed away a few years ago. And he, probably thinks you're him. And that's why he sort of talks to you. This man always came across as someone who had no emotions. He wouldn't express anything. He would have this blank look. He would only recognize me. He would eat, drink, sleep, walk about. But beyond that, there would hardly be much interactions with many people. And I always remember once the caretaker who was in charge of the old age home called me around 9 in the night and told me that this patient has been shouting, Chunilal, Chunilal from the evening, and he wants to probably see you. And I said, she said, he's also a little aggressive. So, you may need to probably help him out medically as well. So why don't you please come and have a look at him? And I went and had a look at him. We prescribed medication, a little bit of medication. Of course, he slept off. He was fine. And 2 days or 3 days post that, he passed away in his sleep. So, the incident just made me feel that sometimes, maybe I didn't realize it, but he had some connect with me somewhere. And, he probably wanted to see me. I also remember when I used to visit these old age homes very often, I would take some eatables, some sweets, some chocolates for these patients, particularly the ones who were non-diabetic, of course, and, give it to them and, just be friendly with them. And this one day I had another lady who was 84 years old who, gave me a chocolate and said, "This is for you." And I said, "Why are you giving me such a big chocolate?" It was a chocolate which was, of course, from abroad. And I think her son had got it for her. And she said that, "No, every time you come here, you give us chocolate. So I have sort of, brought this for you." So she said, "But don't eat it." So I said, "Why should I not eat it?" So she said, "If you eat it, it'll finish. And then I don't have another chocolate to give you." So, so this is the beauty of dementia, at times that, it brings them to the cognitive level of a child or a cognitive level of someone whose intelligence is slightly lower than probably ours. But the fact is that they still feel those emotions. All I want to convey to our viewers today is that dementia does very well in home-based care. I have always been a firm advocacy of home-based care and integrated care at home. And I've always said, please don't send your patients who suffer from dementia to a old age home or a nursing home. It confuses them. It, probably, I think, even makes the disease progress a bit. And what's very important is take care of them. They're more comfortable in their homes. This is something that I have always seen. And let's always remember that, you're not dealing with a patient here. You're not dealing with a brain here. Yes, technically, yes, I'm a doctor. He's a patient. All that is true. But let's remember that at least, in psychiatry, Dr. Krishna Murthy will agree in neuropsychiatry, neurologists will agree in neurology. We're also dealing with people, and we are, combining the science of biology, medicine with the science of human understanding, which is very important. And what's very important is that there's no science other than psychiatry, neurology, neuropsychiatry that allows you to know, no branch of medicine other than these three that allows you to combine human understanding and scientific knowledge. Many other branches treat organs, treat the body. I'm not saying they're bad branches or they don't do their work well. Doctors build bonds with their patients there also. But we are supposed to be more humane because we probably understand the brain, we understand the mind. So let's always remember that we're treating someone who was a very fine individual at one point of time. And I have seen some of my teachers, excellent teachers of mathematics, chemistry today, who are reduced to probably people who are not able to remember anything, and they're under my care. And I just think about 20 years ago and how these people were, and then I think about how they are now. And the only thing that makes me appreciate and respect them is the memory I have of them from 20 years ago. So very often when we get patients that come to us, we may not have that memory because we don't know them. We're seeing them only in their current state. But let's not forget that these were people who were fine individuals at some point of time. And let's give them that respect and dignity, which is very important. Thank you very much.
Thank you, Dr. Avinash. It's a very light side of something as serious as dementia. And I think it's important to remember that they are alive inside. They may not be able to express because they don't find words. It's like a singer who has dementia, who's forgotten the words of the song. So I think we should be singing out to them, touching their chords and reaching out to them. And that's what, care is about. We go on to the last speaker, Dr. Anukan Mittal, also who is very well known as our other members, President of the Indian Association of Private Psychiatry, Professor and Head and at the Department of Psychiatry, Rajiv Gandhi College, Kalwa, Thane. He's going to speak on psychiatric effects of dementia, challenges in the Indian settings. Dr. Anukan Mittal, over to you, please.
Right. Am I audible? Sorry, am I audible?
Yes, sir, you are audible.
Yes, please go ahead.
Yeah, okay. Right. In the Indian context, I think doctors before me have spoken about two aspects of dementia. And they have been primarily of concern since the beginning when dementia was described and detailed. And there were two. One was the cognitive dissonance, and the second was the disruption of activities of daily living. Both of which, in a way, causes a patient to become dependent in a passive way on the caregiver. I'm going to talk about the third aspect, which in the Indian setting, especially becomes very, very, very more troublesome and much more difficult to deal with because we do not have the luxury of large homes and separate rooms and multiple servants. And that is the BPSD, or as we call the behavioral and psychiatric symptoms of dementia. In the Indian setting, we have the problem where a lot of these patients, they live in close quarters with large extended families or are dependent on nuclear families. And when they become demented or when they suffer from dementia is probably the better way of putting it. That is the time when their children, their dependents become caregivers. And at that time, it becomes a very big problem because their behaviors become aggressive, disinhibited, oppositional, paranoid, suspicious, unmanageable, at times very disruptive, and often requiring admission. At this time, we in India have no recourse. As Dr. Krishna Murthy said, as Dr. Nimmel Surya said, and as Dr. Avinash said, that he had to go and give the patient some sedative. At that time, we as psychiatrists have to manage the behavioral problems. And in the Indian setting, the primary issue that comes is who handles which part of the patient suffering from dementia. The neurologist probably makes a diagnosis, does the scans, prescribes the medicines for the cognitive dissonance, and then refers the patient on to a rehabilitation specialist. But as the patient becomes more and more behaviorally discontrolled, when the patient becomes oppositional, when the patient becomes difficult to manage at home, that is when the role of the psychiatrist comes. And then it's a question of us psychiatrists, because the stigma of going to a psychiatrist in India still persists, however old the patient may be. And inadvertently, they will ignore the emerging early signs of paranoia, early signs of depression, early signs of disinhibition, or early signs of obsessive behaviors, till stages are reached where the patient precipitates a crisis, which requires emergency help. Dr. Surya and others talked about patients suddenly disappearing, walking away. Yes, almost 70% of patients above 60 reported as missing from home are patients who are suffering from a dementia. And they're not found. They're never found. Because they keep going. They are otherwise looking normal. They are otherwise capable of normal functioning, normal existence, navigating other aspects of traffic and life. But what happens to them, we have no idea. So we need to be very aware, and especially in our Indian setting, where we have, as all of them said, family as a primary caregiver. we have to be very sensitive. And right from the beginning of the diagnosis of dementia, we have to educate the caregivers to be watchful, especially for symptoms of depression, symptoms of suspiciousness, symptoms of disinhibition, of irrational behavior, of obsessive talks, obsessive behaviors, and seek professional help immediately. Because once something happens which is untoward, especially in a building or a society, there is a lot of negative connotations, negative emotions, and that creates a lot more problem for the family as well as the patient. The other aspects which are specific to the Indian settings are, as Dr. Nirmal said, that there are new drugs in the market. We are very late in getting the drugs. And even then, they're not very easy, they're not very cheap, they're expensive. And for a family to spend on drugs like these and to hear that you have to spend on something which anyway is not going to get cured, it is going to progress. And the end progression is going to be death, where there is no hope of recovery or reversal, becomes a little bit dicey. Because most of our patients, above 70, are on at least 3 to 4 different drugs, one for lipids, one for blood pressure, one for sugar, one for whatever, so they are on 3-4 medications already. And to add 1 or 2 new medications for dementia becomes a burden for them. And that is something that in India, where 80% of the people spend 90% of the healthcare from their own pockets, it's out of pocket. They're even up to now, dementia and other things are not cared for or covered by insurance, which, although the law has changed in the last 2 years, it should soon be covered by insurance. By the time, but till the time it does, the expenses are borne out of pocket by the relatives. So we in India, we face this problem, and especially it's going to get worse because it is predicted by the year 2050, we'll have 40 million people who will be dementia patients. And India, being what it is, this burden may be very difficult for families and caregivers to pick up and take care of as situations get worse. Thank you very much. Any questions? We could probably take it up in the panel discussion. Thank you.
Thank you, Dr. Mittal. So very correct that a lot is to be met with where challenges in Indian settings are concerned. We have one question by Saubik Das, who says, do dementia patients, apart from those affected by Alzheimer's, show roaming and wandering symptoms this frequently? And I think anybody could answer that.
Do they mean other types of dementia? Yes, all of them do. Yes, all of them do. Right.
And what is the frequency? Like, some of them don't at all. And do you find in various types of dementia, maybe the persons with Alzheimer's have more of strain? Because we had a case where a doctor's husband got lost. I mean, he got strayed, he lost his way, and October 27th, it will be the 3rd year now. You see? And
sorry to interrupt you, Vidya. People who exhibit early on in this illness, who exhibit signs of topographical amnesia, right? They go to the wrong flat, get into the wrong building, go down into the garden to sit. When they come back, they enter the wrong building, go to the wrong floor, wrong flat. They are exhibiting signs of topographical amnesia. These are the kind of people who may walk out of the door of your house, go down, walk out of the compound, and then never be able to retrace their steps. So people like these would have exhibited some early onset signs of forgetting the way, what we call as topographical amnesia. And that would be probably.
If I can add to that, I
Yes.
think wandering and losing one's way can also be because of confusion and disorientation.
Absolutely.
And it's also something that people do when they are kind of trying to follow some old habits. We had a gentleman from Kerala with, probably mixed Alzheimer's and vascular dementia was the clinical working diagnosis for him. He moved to Noida to live with his, children in an apartment block. In Kerala, he was used to stepping out of the house in the morning to get his chai. And he would wander off many mornings from the apartment block in search of his chai. And if you ask him where he went, he'll say, in Malayalam, he'll say, I went to get my tea. So in a sense, he was on his autopilot mode based on old habits. And of course, once he goes, he wouldn't know how to find his way back. For the reasons that Dr. Mittal mentioned, and also perhaps because he was confused, disoriented, had not formed new memories of the place he had moved into, and so on. So I think to answer the question, I think people with all forms of dementia can wander and get lost. But I do think there is, in my clinical experience, there is something special about the need to wander in Alzheimer's disease. Those with probable, of course, it's always a clinical diagnosis of probable Alzheimer's disease. They seem to demonstrate it quite a bit.
The thing is, ESK and Anukan Mittal, if we look at Alzheimer's disease, it's a very slowly progressive disease. On the other hand, the other dementia, if you look at the dementia with Parkinson's disease plus, they're very rapidly progressive. If you look at the dementia with multi-infarct or with the other autoimmune disorder or with the long-term epilepsy, they again are very, very rapidly progressive. So they do not give a patient time to wander. In fact, by the time patient really been diagnosed, they are already either into a severe confusional state and the relative has already identified that this is a serious state and they have been warned. So Alzheimer's itself is a very different sort of a preposition as far as we're concerned about the disease spectrum. It's only some of the treatable dementia which get treated, patient get better. So you may not see that much of a wandering and roaming, what you see probably in all Alzheimer's cases, because they all are very slowly progressive. And at stage 2 or stage 3, you're bound to see them.
Yeah, that's a nice way of seeing it. You know, the different types of dementia have different effects. And, as you said, what I'm told is it takes 15 to 20 years for the onset of the dementia symptoms to show, Alzheimer's symptom. So it's probably that's the reason that, you miss it. And I think culturally also, we believe that it's the age that is is playing in this change. We don't have many questions, but one thing I want to say is...
There's a question from Shirin also.
Yeah. There's one where she says, 1 minute. Yeah, she says, Dr. Shireen Barodawala, she was head of JJ Hospital Neuropathology Department. She says 5 million plus cases of dementia in India is imaginary, in line with 3.0% of dementia cases above the age of 65 years. There is no large-scale epidemiology studies to talk about. Secondly, by and large, we have extended caring family environment and low-protein diet. So AD is not to worry, but vitamin B12 deficiency and hypothyroidism may form a large chunk of dementia patients. So who would like to answer, or, all can answer.
Can I take the epidemiology study bit? There have been a few, and they've all looked at populations between 1,000 and 3,000 elders in the community. I agree that there haven't been very large-scale studies, but I think NIMHANS at the moment is leading a fairly large-scale study of brain aging in the elderly across the country. I think Suvarna is the principal investigator. So we should hear more in the future about with Indian data. India was part of the ADI effort, which was the 1066 project. And we've had other people like Mathurunath do fairly large studies in Kerala, where he gave the Addenbrook's cognitive examination to, I think, almost 3,000 elders in the community. So I think epidemiology, in a sense, it's available, but I agree that we could be much better than we are as of today.
Well, I agree with ESK that there are many more epidemiological studies are coming. And if you look at the couple of publications, though it has not been that large, and you won't expect 10,000 and 20,000 people being studied. But by and large, we are following the pattern, which is we initially thought Alzheimer may not be as serious as in the Western world, but obviously we have been seeing more and more cases as the epidemiology is showing up. I agree that vitamin B12 and hypothyroids are treatable dementia, but believe me, Dr. Barodawala, in last 10 years, we have not seen many cases of B12 dementia. Yes, when I was resident, we were seeing many more cases of B12 dementia, because in those days, to do the serum B12 level was not possible. Today, the B12 thyroid is part of the normal routine annual checkup. And therefore, many of these patients are picked up very, very early and been treated for the B12 deficiency. So I think we are shifted over from, and yes, in every cases, as I mentioned right in the beginning, one should look for treatable cause of dementia, which includes B12 thyroid, NPH, multi-infarct dementia, and some of the brain tumor, particularly frontal lobe, can present with the dementia. So these are some of the treatable causes which one has to look at. Not to forget, in India, some of the Ayurvedic Bhasma can also give rise to the dementia, and therefore those people who are taking for years the manganese or mercury, we need to screen them and find out and look for that. It's always good to look for other causes of dementia when you are a patient. And I'm sure all neurologists are geared for that.
Thank you, Dr. Surya. There's one more question. Dr. Rajeshwaran and Dr. Krishnamurthy spoke of the importance of focusing on quality of life. What could be some of the ways by which caregivers can ensure better quality of life on a day-to-day basis?
Can I take this question?
Yes, please.
Yeah. I did speak in my talk that about 3 aspects one needs to keep in mind when we talk about quality of life. First, taking the individual itself, where we need to ensure that they don't have any other medical conditions or psychiatric conditions. For example, dementia comes with depression. So treating dementia along with depression becomes mandatory. They do have cognitive deficits. So when we talk to the patient, they don't understand or they repeat whatever we say, the caregivers don't understand these aspects. So we need to educate the caregivers regarding the cognitive deficits that the individual will have. And they do have aches and pains, which they are not able to express it, which the caregivers should be sensitive enough to pick it up and then handle those issues. And many a times these patients are treated as sick patients. They are not engaged in routine conversations, nor routine tasks are given to them, or they are kept engaged. So they have to ensure that these patients have some tasks to carry out through the day. Then communication becomes a very important issue. The caregivers should not be shouting at them, yelling at them, blaming them, or negative tone and negative language impacts the individual. So that is another important thing that caregivers need to be educated about. And expectation. I did say about the expectation. They expect the patient to do whatever they say, but the patient is unable to do. So they need to be educated that the patient has not understood it or not processed it or not comprehended. So these are the things that we need to educate the caregivers. Their own stress and coping plays a very important role. So they get, especially in moderate to severe and severe dementia, burnout sets in. So we need to take care of their stress and coping. Their poor health condition is another issue which we need to address and then ask them to take treatment accordingly. And they should carry out routines which can be predicted. They cannot bring new tasks every day and give it to the individual. They have to keep them engaged, but they can predict, yes, this particular task or this particular conversation, the patient is able to understand or not understand. And if they have poor interpersonal relationship in the family itself, that can impact the patient. So all this we need to take care with the caregivers. And of course, again, the environment also needs to be kept in mind. The complexity of the environment, the noisy environment, the cluttered environment, all this needs to be educated upon with the caregivers so that the quality of life of the dementia patient is better. Thank you.
I think it's, it's important that love and tender care is very,
Yes.
very, it's just indispensable. And, COVID has done that. It has brought us together. It has given us time for family members, especially elders who need companionship. And it's also, made us aware that we can do even however busy we are. Or something like, people are working from home and they wonder why, because they can't think right. So they say, how come the children are working from home? Have they lost their job? The children have not gone to school. Have they stopped going to school because the children couldn't pay the fees? So these are the things that cross their mind and they cannot speak it out. And I think, customized attention, customized services. I think these are the things we need to be giving sensitively and unconditionally, because the more unconditional you are in your care, I think one reaches higher dividends. And I'm sure all of us in our own way professionally have been connected with person-to-person treatment. So I think we've answered all the questions.
You have enough. You have
Yeah.
enough hand raised.
I can't see that. One moment. Just a minute. Dr. Abhishek, could you please take that? Because I can't see the hand nor the...
I can see that.
Okay, please.
So I'll ask a simple question to most of the panelists regarding pharmacotherapy in Alzheimer's disease. So when do we start pharmacotherapy to improve cognitive and linguistic function? And how long do we continue it? When should we stop it?
Shall I take that, Abhishek?
Yeah, all of you can contribute in that.
I think whatever drugs we have available, both the acetylcholinesterase inhibitors and the NMDA receptor agonists, are both for diagnosis of dementia. There is the use of them in mild cognitive impairment is still not something that in many countries is licensed. Having said that, as early as possible is what we need to think about. The choice of the acetylcholinesterase inhibitor is not particularly differentiated. A little bit of preference of donepezil for vascular dementia, a little bit of preference of rivastigmine for Parkinson's disease and dementia is there, but by and large not particularly differentiated. And of course, those two cannot be combined. So you can only give one acetylcholinesterase inhibitor at a time. And of course, you can combine that with memantine, which is the NMDA receptor agonist. So as early as possible, start low, go slow in titrating. Tolerability is a very important factor. Many people get gastrointestinal symptoms with the drugs, and that becomes a reason to reject the drug. And of course, in our culture, many people don't understand that this is a long-term prescription. So they'll tell me, oh, I took it for a month and then I stopped. Or I gave it for a month and then I stopped. And of course, we need to keep re-emphasizing that they can't stop. They have to keep giving it. So I think this is, as far as this is concerned, the general tendency today is to avoid the use of psychotropics, antidepressants, antipsychotics on top of these drugs, because they do seem to contribute to increased morbidity and problems. So, of course, we are forced in practice sometimes to introduce these things because the symptoms are so severe. But advice is to try and avoid. When to stop is an even bigger problem, simply because whenever you stop, you can get a rebound of symptoms. So stopping also is something that one has to do very, very gradually. Usually when it's advanced and kind of burnt out dementia, where there are very few symptoms and the person is largely withdrawn, that is a time when definitely we do consider stopping. But if you go by the clinical guidelines in the West, which are partly driven by many other factors, they consider stopping after 6 months, 1 year, depending on which country you're in. So, but most of our patients are on it for a very, very long time.
Dr. Krish, I have a question to you regarding this. Have you tried cognitive training and with the drugs? Is it more beneficial?
Yes, we greatly believe and endorse in the value of cognitive retraining as a constant. And we believe that we need to train families. So in fact, to answer the earlier question, patients with dementia, as you pointed out, respond well to a rhythm, and sharing of care among family members and choosing tasks for cognitive retraining that are interesting to them, we find is extremely important. So we have one person who likes Rafi songs, and a lot of our sessions are spent singing with him. We have another person who is a doctor who loves revisiting the old books of medicine. So many of our sessions are spent revisiting the medical book with the person. So
my question was, have you tried medication with cognitive retraining and cognitive retraining alone or medication alone? Does it, I just want to know the add-on of medication and cognitive retraining, does it have a better benefit as compared to only one of these?
Okay, in personal experience, we use both and more in all our clients. So I'm not very certain in my own practice. We give everyone medication, we give everyone cognitive retraining unless the patient does not want it. But I think in terms of published work, I think there definitely is a benefit in combining routine pharmacological interventions with cognitive retraining. That I think that definitely is there. There are very few non-pharmacological studies, and part of the problem is that they have to be naturalistic in the sense that routine care continues, and on top of that you add the non-pharmacological intervention. To study the impact of a non-pharmacological intervention on an untreated patient, as Dr. Professor Jamuna will tell us, is very, very difficult as a consequence, because withholding treatment is very challenging. So,
thank you.
So there are 2-3 things which I want to add on to Chris' thing. One is, of course, he has very well explained about the medication. But I must tell that there are some patients who refuses to eat the medicine. And that's a real challenge, particularly in the second stage or third stage of the disease. And therefore, the patch is something which is a very, very big savior. So Axilon patch, you can change every 24 hours, put on any part of the skin where there are no hair. So Axilon patch has been a very, very useful drug. And we have seen in many of these patients, Dr. Jamuna, when we started a timely therapy with the rivaroxaban patch, it has definitely helped the patient in reversing the symptoms to the tune of 20 to 25%, and then slowing down the progress of dementia. And I think that you need to start the medicine to the patient. The patient become a little bit, family become more confident with you. Take it forward with cognitive retraining so that he become cooperative, because many of these patients do not even trust the doctor on first or second sitting. Therefore, my practice we follow is start the treatment, let the patient get a little bit better, they have more confidence, and then you add on to the cognitive retraining, which we do, and then they continue to do that. The treatment, as ESK has mentioned, has to be a very, very long term, and which we need to explain them time and time again.
I think we are nearing time. I'd like Dr. Vidya to please summarize the session.
Yeah, I think we've learned a lot, both pharmac, non-pharmac. More importantly, I think we've touched the sensitivity of our practice, and we understand that people need us, but I think we need them more because we are more concerned. And I think that's the way we buy our peace, by looking after them the way they should be and how they have looked after us. I'll just close saying that it's been a wonderful session, very balanced in neurological and in psychiatric approach. It's complete. We've got very positive feedback from people who've attended the session. And I can just close saying that one message, let us remember those who cannot remember. And I give it over to you, Dr. Abhishek.
Thank you, Dr. Vidya. So I would like to thank WFNR 25th celebration here, ARDSI, IFNR, all of the speakers, our moderator, all of our listeners for this excellent webinar on Alzheimer's disease. I think all of us have learned something. At least I have learned some compassion, give more compassion to our patients, improve their quality of life, and combining pharmacotherapy with rehab in a multi-scenario approach is the name of the game, and I hope you all will do in our practice. Thank you very much. Thank you, IFNR, WFNR, ARDSI, brilliant session. Thank you, speakers. Bye-bye.
Thank you, everybody.
Thank you. Thank you for a great time.
Just to mention that we will be doing regular webinars on similar issues on any of the interesting days, and we look forward to have you again and again to come and enjoy our.
Sure. Thank you.
Great announcement, Dr. Surya. And you made, I mean, once Dr. Surya says something, it's achieved. And with a panel like this, I think the sky is the limit. So we are going to benefit sharing and caring, and the audience is going to learn a lot more. Thank you for a wonderful time. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye. Bye, everybody.